We are live.
Good evening, everyone. I welcome you to the next second module of our DOS postgraduate education program. And thank you all for the great response to this oculoplasty module. Almost 760 residents have joined us for that program. And now we have a understanding with ANBAI, and their institutes are also going to join us for this retina module. And before starting anything, I would like to uh, express my gratitude to Lalit Verma sir, because he has helped us in planning this program as well as deciding the speaker. So I'm 100% sure it's going to help you all hugely. And for today, Lalit Verma sir is going to be the chairperson, and Dr. Pranita Sai is going to coordinate from DOS side, and Dr. Anita is going to coordinate for ANBI institutions. So, Pranita, I would like to request you to introduce our chairperson and speakers for today, and then we will move on to the session.
Thank you so much, sir. So, welcome everyone to the second module of DOS PEP. We have already been through this program for 3 months, as sir has already highlighted the same. So, we'll move on to the introduction of chairperson, Dr. Lalit Verma, sir. He needs no introduction. We all know him very well. He's done his post-graduation senior residency from RP Center, AIMS, and has been a consultant at AIMS for over 14 years. Currently, he is a senior vitreoretina consultant at Center for Sight Eye Hospital. He's been the past president of prestigious associations of AIOS and DOS, and he is also the Congress president of the upcoming APO 2025 Congress, which we are going to have in India. Welcome, sir, to the Retina module of DOS PEP, and we are really looking forward to your positive comments and response for the program. We would also like to welcome Dr. Anupam Sachdev, sir, and express our thanks for collaborating, having the ANBI collaboration for the DOS PEP module. Sir is the co-director at Institute of Child and Health at Gangaram Hospital. And I would also like to welcome Dr. Anita, who's our course coordinator along with me for this DOS PEP. Dr. Koushik Tripathy, the speaker for today, he's done his post-graduation from AIMS and senior residency from AIMS. He has also achieved the FRCS Glasgow, DNB, and various other degrees to his credit. He is currently the medical director at the ASG Eye Hospital in Kolkata. He is the secretary of the academic cell at ASG and also the ethics committee at ASG and various other important positions. He is also the editor of the retina and vitreous section at the Wikipedia module for retina and for the StatPearls, and is a reviewer for various international and national journals. He has over 250 publications. With that, I would like to welcome Dr. Koushik Tripathy, sir, for our first lecture on the topic Anatomy and Physiology of Retina.
So, Pranita, just 1 minute. So, we have our president, Professor Rohit Saxena, with us today. Sir, would you like to say a few words?
So, thank you, Praful, and it's an absolute pleasure to be here in the august presence of Dr. Lalit Verma, one of those who all of us have learned whatever retina I know, of course. Of course, that's not his fault that I know very little. But whatever retina we know, including, I'm sure, Koushik, we all have learned so much from Dr. Lalit, and it will be an absolute pleasure to hear his comments. And again, absolute pleasure to listen to Dr. Koushik. He's been with us at RP Center, and even as a resident, his diligence, his hard work, and his passion for knowledge and doing great work has always been there. So great, it's a wonderful thing. And this retina module, I think, is the most essential part of any residency training, and I think for all ophthalmologists to know at least something about retina, so that you know what you can treat and what and when should you refer these patients to. Thank you, and Praful, and all the best.
Just to add on to that, sir, Lalit Verma sir has personally seen the program, and he has also recommended a lot of lectures for the specific classes. So it's definitely going to be a very useful program.
Actually, I'm very happy to see DOS is on the move, and the executive led by Dr. Rohit and the entire executive and Dr. Praful and so many other people are working very hard. And they have just finished Winter DOS, a very successful event. See, PEP, what is very, very close, and I know the entire hard work Praful has done, and he's passing on to us, but he has done the basic hard work. What I liked about Praful, this was the gradual ascent. Ascent means that you start with anatomy, physiology, diagnostics, and then go on to surgery. And this slow building up the story is the best way where postgraduates would benefit, rather than straight away jumping to specific topic like PVR, which may not immediately benefit. But if you built up the story like this, anatomy, physiology, then diagnostic, then diseases which all of us face, it's very nicely the way it is formatted. And I'm sure this will go a long way in enriching the knowledge, not only of PGs, but whosoever is, listening, that they will definitely get benefit. Another good point is that this time, this AN by ANBAI has joined hands. This will further strengthen the pursuit both common DOS and ANBI will have. And Koushik, I know for a very long time now, and he's a very learned, very clear in his concepts, and a very learned man, very well-trained retina surgeon. And let's hear his talk on relevant anatomy of retina and physiology. Thank you.
Thank you, sir. Dr. Anita, just a few seconds, would you like to just update us about ANBI? Because a lot of people may not be knowing what ANBI stand for. And a lot of students have joined from the ANBI platform. So, Dr. Anita, are you there?
Yes, sir. Good evening, sir. Good evening, Dr. Rohit, sir, Dr. Lalit Verma, sir. It is pleasure to hear from you, sir. Sir, ANBI includes all the DNB institutions in Delhi, uh, even the private one where the DNB students are there. So this is whole association is there. So in which we would be happy including all the other residents which are not included in DOS group. So additionally, they will get the benefit. So it's a very nice initiative that you have associated with this association as well. So more or more residents would be there.
Thank
And
you.
this talk would be very informative, I'm sure. Dr. Kaushik, definitely. I have even learned from him.
Okay. Thank you so much. Koushik, now you
Yes.
can start your talk, please.
Thank you, sir. So I thank Dr. Praful sir, Dr. Rohit sir, Dr. Lalit sir, and ANBI for giving me the opportunity to present on anatomy and physiology of retina. I am practicing at Kolkata in SGI Hospital, BT Road. So I'll be discussing the nomenclatures of retinal anatomy, and specifically I'll focus on the clinical part, ophthalmoscopic anatomy, anatomical versus clinical landmarks, histology of retina, OCT of retina and its anatomical correlates, findings on fluorescein angiography and its related anatomy, what are the other imaging devices, and the anatomy they show, and also physiology of vision and color vision. So basically, retina comes from, the name retina comes from rete, Latin word, termed net. So the vasculature of retina, it looks like net. So that's why the name comes. Fovea, because this is a depression. So this is in Latin, the meaning of fovea is spit. Macula, the macula lutea, which central part of the retina is called, the name comes from Latin macula, which is stain or blemish. This same macula term has been used for skin lesions and also lesions in the cornea, opacities in the cornea. And lutea because it looks yellow, specifically on post-mortem slides or histopathological slides. So as we see that the fovea is not exactly temporal to the disc, it is like if you draw a horizontal line from the fovea, it will be passing through upper 2/3 and lower 1/3 of the disc. It is around 2 disc diameter away from the temporal disc margin. So it is disc diameter is around 1.5 millimeter, so that comes to around 3 millimeter. And it has like there are multiple names of the parts. So umbo, it's around 150 micron at the center of the fovea. Then foveola is 350 microns. Then when we enlarge it more, there is a fovea which is oval or round area of around 1500 micron. And then anatomical macula is the area within the arcades. It is around 5 to 6 millimeters, or 500 to 600, 5000 to 6000 microns. So, and paraphobia is the area around the fovea. The width of this area is around 500 micron, and outside this, with the area is called perifoveal region. Say, as you all know, so we need to identify the veins and arteries also, because there are few diseases which involve veins, few diseases which involve arteries, specifically in vasculitis. So the arteries are brighter red, and they are smaller in caliber, and the veins are like darker in color. So in ophthalmoscopy, you can see that the vortex veins are marked. So these veins denote equator. So, and clinically, the clinical macula is anatomical fovea. Like when we call it is macula of, that means the fovea is getting detached in a retinal detachment. And clinically, we say posterior pole. That means that the lesion is within the arcades, or it is correspond to the anatomical macula. So outside the posterior pole and behind the vortex veins is mid periphery, and peripheral to the mid periphery or peripheral to the vortex vein is called peripheral retina. So this is an optos image which is around, which takes around 200 degrees of field. So in histological anatomy, we need to learn by heart the 10 layers of retina, which includes retinal pigment epithelium, photoreceptor layers, external limiting membrane, outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, ganglion cell layer, nerve fiber layer, and internal limiting membrane from outside inwards. So this and also this amacrine cells, they synapse at inner plexiform layer, and horizontal cells, they synapse at outer plexiform layer. So this is another important thing which is very important for the PGs, that is to remember or learn this thing by heart, the areas of retina, anatomical correlation to the OCT. So this is the international nomenclature. I have given the like details of the publication also. So it is recommended that all the candidates should read this interesting article. So all the you have to remember this area. So from inside outwards, there is vitreous, posterior cortical vitreous, preretinal space. Then there is internal limiting membrane. Then there is nerve fiber layer. So sometimes you can see when you are examining the OCT, you should see layer by layer. So in glaucoma, you might be able to see that the nerve fiber layer is thinned. Then there is ganglion cell layer, inner plexiform layer, the inner nuclear layer, outer plexiform, outer nuclear, then external limiting membrane, then ellipsoid zone, and then RP. So the darker areas are nuclear layers, outer nuclear and inner nuclear layer, and other areas are hyperreflective according to their reflectivity. So this is the same way in Zeiss Cirrus OCT machine. So they actually the nomenclature advised that we should avoid the term line, like inner segment, outer segment, junction line, because it is in anatomy there is no line. It is a line is a one-dimensional thing. So we are instead using band or layer for areas for defined laminae, like inner plexiform layer, outer plexiform layer. And zone refers to regions or regions of tissue that cannot be clearly delineated from each other with present technology. Basically, the histological correlates are just presumptions only. So this zone include ellipsoid zone. So this is the proposed histological correlation of the OCT findings. So The hyperreflective areas include external limiting membrane, ellipsoid zone, and then the interdigitation area, and then the RP. So there is another concept, that is neurosensory retina and RP. So the retinal pigment epithelium and neurosensory retina, they are embryologically derived differently. So there is a potential space which we see that there is subretinal fluid accumulation in different diseases, including rheumatosine retinal detachment and exudative retinal detachment. Exudative retinal detachments are caused by multiple diseases, including CSCR, central serous choroidiopathy, and BKH. So the neurosensory, this is neurosensory retina and this is RP, and there is a potential space. There are multiple factors which act to keep the retina in place. Retina and RP should be like connected to each other by various forces. So this is fluorescein angiography correlate. So as you see, the area, that central dark area which is devoid of blood vessels, is called the foveal avascular zone. So we have currently got OCT angiogram, which is non-invasive technique, and in that you can actually see superficial plexus, deep plexus, and also details of the choriocapillaries. You can see the areas of segmentation. That means the area through which it is getting samples. So various machines have various capabilities. So superficial vascular plexus can have two in advanced machines. You can see nerve fiber layer vascular plexus and superficial vascular plexus. Then deep vascular deep vascular capillary plexus has also two components: intermediate capillary plexus and deep capillary plexus. Most of the machines are not able to pick up that intermediate capillary plexus. So we have to understand the retinal vascular supply, because the fovea, the central part of the retina, is actually supplied by choriocapillaries, and the inner retina is supplied by retinal arteries. So the significance of this is that when there is retinal detachment, the neurosensory retina is actually not getting any nutrition. So the longer you wait for the retinal reattachment to occur, the retinal tissue or neurosensory retinal tissue will degenerate with time. So in physiology of vision, so we need to understand that the mechanism inside the brain or animals, they perceive stimulus in a logarithmic fashion, and it is not linear. So this has been integrated in our visual field machines also, which as you can see in the apostiles are actually logarithmic: 1, 10, 100, 1000, and 10,000. So it signifies the brightest light and dimmest light. And also, as you have already known, that we are currently preparing logmer charts, so that we can actually quantitate the visual acuity correctly. So in physiology, we need to understand that there are two major cells, two photoreceptors: rod cells and cone cells. Rod cells are predominantly required for night vision, and there are around 120 million rod cells. They are very sensitive to light. Mostly they help us in night vision, and it has achromatic vision. That means black and white vision, and resolution is low, because many rods, they actually report to one bipolar cell. Cones are more prominently focused in the fovea, and they help us in visual acuity or seeing or reading. So there are around 6 million cone cells. They are responsible for the color vision, and they have high resolution. They are reporting to one bipolar cell. So what is the ionic basis of like vision? So what happens in the photoreceptors are depolarized in dark. So when light falls, it causes hyperpolarization. So how does it happen? It actually closes the sodium channels. The sodium channels in the outer segment of the photoreceptor. That actually makes the photoreceptor negative or depolarizes this. So, and on another thing is that in photoreceptors or bipolar cells, the transmission of most of the signals occur via electronic conduction and not by action potentials. Action potential are seen in ganglion cells. So this is the detailed process of phototransduction in light. When light falls, 11-cis retinal is converted to all-trans retinal and it dissociates from the rhodopsin. That in turn activates transducin and phosphodiesterase, which degrades cyclic GMP, and decreased cyclic GMP will close the cation channels, and that causes hyperpolarization and glutamate exocytosis is stopped. And in dark, the reverse happens. 11-cis retinal is bound to rhodopsin in the outer segment of the photoreceptor, and it inactivates transducin and phosphodiesterase, which stimulates the opening of the ion channel, and there is depolarization. Sodium influx is there, and there is depolarization, and there is release of glutamate from the synapse. So another important thing is once visual cycle, when light falls, it actually converts 11-cis retinal to all-trans retinal, and there are multiple enzymes involved, and they have been targeted to treat various genes. So there are various inherited retinal diseases, and most of them are somehow involved in the phototransduction or visual cycle. So dark adaptation, in dark adaptation, when we go from light to dark, there is a mechanism by which we gradually start seeing. So this dark adaptation, the preliminary part is mediated by cone, and the later part is mediated by rods. So this is severely hampered in retinitis pigmentosa cases. So the theories of color vision, predominantly we use trichromatic theory, in which we have actually 3 types of cones. S cones, which are short, which are mostly responding to short wavelengths like blue, purple, for 440 nanometer, and then M cone, which responds to green, and L cone, which responds to red. So my take-home message would be: remember the retinal layers by heart, remember the OCT layers by heart, and remember the retinal vascular supply. Thank you. And I thank Dr. Trina Singh Gupta, Assistant Professor Physiology, for helping me with the slides. And I'll take this opportunity to request you to contribute to iWiki, which is a Wikipedia, and global ophthalmologists can contribute to this. And if you contribute, your name is there forever. And this helps us in contributing to the global knowledge. Thank you. It is always free. And if you have any trouble in joining here, you can actually contact me. Thank you. Thanks to DOS leadership for giving me the opportunity to present.
Thank you, Koushik. That was a wonderful lecture, and actually, we had requested Koushik to keep it simple, because if he starts teaching you each and everything, then you people won't be able to remember the every minute details of anatomy and physiology. The basic point for you people is these are the main important clinically relevant points for retinal anatomy, and you'll have to go back and study. Right, that is the most important part. And do we have any comments?
Dr. Lalit, sir, please.
No, I think Koushik, obviously he hasn't gone to depth of what we were taught as Wolff's anatomy and Adler's physiology. That I think takes a long, long time, and that's not the whole purpose of webinar. Webinar is a clinical, correlates. That is more important, and which we has very nicely specifically, because OCT has become, part and parcel of all retinal evaluations. So he has very nicely emphasized and shown the pictures. He did touch a bit about physiology, but physiology is quite complex. Visual physiology not so straightforward. And Wald, who actually won the Nobel Prize because of this, visual cycle for the one of the few ophthalmologists who have won the Nobel Prize. Other thing which I think Koushik very nicely emphasized was that RPE and the 9 layers are embryologically different, and therefore what we use, retina has 10 layers, which he started with. So one part in detachment, what happens is a misnomer actually. It's not detachment, it's not a detachment, it's a separation. So 9 layers separate, no Koushik. So 9 layers separate from the ectodermal layer, which is the RPE. And other thing which I think, because therefore, once we talk about detachment, is actually retinal separation. And he also told about that why it's an urgency, because the rods and cones, they get blood supply from the choriocapillaries, and if they get separated for a long time, they die. And if they die, then obviously then surgeon is not to be blamed. Although retina is in place, you may not get the vision. So and the alignment of cones in the macula is like 1:1, like this. And this may sometimes take time. Remember, if there's a fluid between 9 layers here and 1 layer here, there's a fluid which we drain and gets absorbed spontaneously. It may take long time sometimes to align, like this cone, like one cone to one bipolar cell. That is the reason sometimes the visual improvement may take weeks and months, especially if you don't drain. Because remember, the fluid is bathing all these rods and cones, and thicker the fluid, more proteinaceous the fluid, more time it may take for visual regeneration. Although anatomically we may say retina is on, but still functional, recovery may take a lot of time. Rest was good. What else? So, any questions from the listeners? So, I think Koushik will be very happy to take them.
There is one question which is Dr. Pooja. She wants to know if the OCT layers that are depicted, do they exactly match the histopathology of retina, or there are some errors because of imaging and reflection, all this thing?
These are just clinical correlates. Like histopathologically, they have not. They are a like this might not be the exact correlate of the histology in specifically the outer retinal layers, but we have like evidence to support the current like classification, in which like almost all the layers are actually shown. So basically, this is a optical biopsy of a like live human being, live animal, and in which you can actually see what is happening histologically.
So,
So all
actually, it is not a biopsy, because histology is not a histological biopsy. So,
yes,
histological correlate may not be exactly. But
yes.
for better understanding of all, like he's saying, the difference between histology and optics. So it will tell you all those 3 cells in the retina, that it will tell. But each and every matrix, but suffice to say, from the clinician point of view, these cellular layers are darkish, and the plexus layers are whitish. And depending on the density of the plexus, you will have reflectivity. Like retinal nerve fiber layer will have more reflectivity compared to the outer plexiform layer.
Basically, this is tracking the reflectivity of the layers. That is what it's doing.
So
And
it's not
also,
exact. It's not an exact histology.
yeah, not exact histology. And also, if you like, if the images are taken like by like rotating the machine, or sometimes you can actually see Henle's layer. Like as sir said, when the light is like passing parallel to the cells, then it will be hyporeflective, like cones and rods, which is outer nuclear layer. But when there is a plexus, like horizontal thing, and light is passing perpendicular to that outer plexiform layer, inner plexiform layer, nerve fiber layer, it will be hyperreflective, or it will be if you are like in color coded area, it will be redder, more red, like RPE or nerve fiber layer. And the areas which reflect less light, will be darker.
But from the point of view of PEP, and the post-graduate education program, everybody should mug up these 10 layers from either side, either from inside out or outside in, because that is one of the most common questions asked, and a lot of people falter on that.
Koushik, there is one more question from Dr. Manvi. What is the clinical significance of this different blood vascular supply to the retina?
We
Because
have
retina
already
is supplied by, yeah.
if there is a like retinal arterial occlusion, then what basically retina is a tissue part, it is transparent tissue. That's why you are seeing the choroid, RP. So once there is central retinal arterial occlusion or branch retinal arterial occlusion, because the branch retinal artery, they supply the inner retina, so the inner retina will be white. And as I showed, the macula, the central fovea is not having the inner retinal layers. So that will not have whitening of the retina. So from that area, you will see the reddish glow of the RP and choroid. But from the other area, where there is retinal arterial occlusion, the retina will become white. So that will give you a cherry red spot. And also when if there is a retinal detachment, regmatous retinal detachment, then because the retina is separated and inner retina, like outer retina is not getting supply. So outer retina means the rods and cones. So because as Lalit sir told, so if the rods and cones are not getting vascular supply, they'll die eventually with time. And the longer you wait for the surgery, the worse is the outcome. So that is the clinical correlate of supply.
So, like very rightly, Koushik has said, the blood supply of, if you talk of all the 10 layers, is dual. One is from retina, other is from the choroid. And from the retina also, there is, superficial plexus, deep plexus. And if you see, which I think in the other module lectures, you will have octa and other, modalities, modalities. So there is a preferential involvement of, say, deep DCP, what we call deep capillary plexus in diabetics. So after we necessarily study DCP in diabetic retinopathy, and there have been reports that deep plexus tends to get involved earlier before the other plexuses. So apart from what Koushik has said, you see the ciliaretinal artery, sometimes if patient is lucky, then if ciliaretinal artery is spared, patient may still have 6/6 vision despite CRA block. So ciliaretinal artery, that's the importance. And retina, like you said, is transparent. Whatever we see fundus, the color is from the choroid, not from the retina. So therefore, if RP gets atrophy, like in albinism or some very high myopic fundus, then you see a choroidal sclerosis. Choroidal sclerosis, there's no sclerosis of choroidal vessels, but it is the ease of visibility because of the RP atrophy, and we see the choroid vessels very well. So all the large vessels are seen very, very well.
So also another thing is like in if there is a problem in deep capillary plexus, you can find something what is called paracentral acute middle maculopathy, PAMM. Interested people can this. It is a classical finding on OCT.
Well, Koushik, there is one more question, and this is one of our first semester resident who have just joined. What is the difference between CME, CSR, and RD anatomically?
CA?
CME, cystoid macular edema, CSR, and retinal detachment.
So basically,
Anatomically.
retinal detachment and CSCR cannot be like if you have a small scan of a OCT, this is a retinal separation. It can happen due to multiple causes. So you should not say that there is a central serous retinopathy by seeing at the OCT. For diagnosis of CSCR, you need to find out the margin of the retinal detachment. Thus, in central serous retinopathy, typically the retinal detachment, the exudative retinal detachment, is the central. It is an oval or round circuit area with all surrounding retina is attached. And also, you have if you do angiography, you will find classical findings including ink blot leaks or smokestack leaks or diffuse leaks. So in
the
retinal
problem is that the fluid collection in CSR and in RD is at the same place. So fluid collection, whereas in CME, the fluid collection is primarily in the outer layers, what we call Henle's layer. And therefore, if you see the angiography, you will have a, therefore in angiography, we definitely recommend and request the technician to take late phase. Late phase means not 5 minutes, not 10 minutes, sometimes 15 minutes also. Then you will get those cystic spaces and a typical flower petalite appearance. Whereas in RD, you don't get those because the fluid collection is elsewhere. If Henle's layer, if you have fluid collection, and that CME, the fluid collection is by and large symmetrical. Whereas in DME, it may be asymmetrical. So the way to diagnose CME, and sometimes this is a therapeutic implication also. If I diagnose CME, I'm more inclined to give imesaptine on tricot. Whereas if I see diabetic maculopathy or this thing, I tend to give him anti-VEGF inhibitors. So I think question is very relevant. So a lot of times when we were of your age, first semester resident at RP Center, there's usually interchangeable, terms like macular edema or CSR, which I still remember my professors telling macular edema हो गया उसको, लेकिन वो था CSR. So CSR actually is detachment. The fluid is collected between the RP and the rest of retina, as is there in RD. But in CME, it is in the Henle's layer, and therefore on angiography you get a typical symmetrical. If you have the fovea like here, so dono taraf you will have fluid collection and some cavities, and it has therapeutic implication also. I think question is very, very important and very intelligent question also. Professor, you are muted.
There is one more question, Koushik. When we laser retina, which layer of the retina we are actually hitting with laser?
So that will depend on the laser, because the laser, there are multiple tissues which have different absorbance, highest sensitivity to the laser. So if you are using green laser, so actually we are targeting the RP and the outer retina. We are trying to coagulate that, and also if the burn is more, the inner retina may also be affected. The specific laser uptake is at the RP. So if you have retinal, this is another clinical implication. If you have difficulty in understanding retinocysis or retinal detachment, senile retinocysis and retinal detachment, when you laser in senile retinocysis, if there is no retinal detachment, it will take laser. The laser pulse, like white pulse, will be coming. But if there is subretinal fluid, that means retina is detached from the RP. If you laser, it will not come. So, and Dr.
So the other thing is that higher the wavelength, deeper the penetration. So broadly, Koushik has very nicely said. But the commonest laser used nowadays is double frequency YAG laser, that is 532 laser. The maximum absorption of that is in the RP layers and outer retina. But when we were at RPC, we used to have blue-green laser, that was 488. So you should remember, like he started his line very clearly, depends on the laser wavelength. So 488, it's more absorption inside. Then 532, you go deeper. So, and then diode laser 810, you go in the choroid. So diode laser, the issue is once you hit a spot like this, patient jerks like this because it causes pain. Retina is painless, but if this goes deeper, patient gives a jerk reaction, primarily because you are using higher wavelength, and that happens in diode. So we did compare a lot of times, there are a lot of articles published, the histopathology correlates, where does the reaction come of the laser. In diode, it will come primarily in the choroid. As you decrease the wavelength, it moves anteriorly. So remember three wavelengths, 488, 532, and 810, meaning blue-green, the double frequency green, and the diode. These three wavelengths. And histologically, you will see the cellular reaction at deeper levels with higher wavelength.
Thank you, sir. And this is the last question from one of our residents, which says, can there be retinal detachment in cases of optic nerve PET?
Yes.
So Koushik will answer this. Koushik, because he's a learned person.
So basically, retinal detachment, when the RP is getting separated from the outer retina neurosensation, that is retinal detachment. So optic disc maculopathy, it is typically characterized by cysts at my multiple level. Cysts means there is intraneurosensory retinal separation. There are multiple small cystic cavities, vertical cavities lined by bridges, and there can be a subretinal fluid at localize the macula. But in if the morning glory syndrome and other cavitary abnormality, including optic disc pit, have been reported associated with retinal detachment also. So that can also
But the answer what whosoever asked this question, typically again when we were students we used to say 1/3 of PIT patients have CSR, but that is not true. It's not CSR. It is the fluid is totally different. It is not CSR. It is not between rods and cones mostly. It is intraretinal, and this you can very easily document on OCT. So what is known as typical Cronenberg syndrome? Cronenberg syndrome is optic disc-associated maculopathy, where you will not get leaks like ink blot leak or smokestack leak or inward smokestack leak in shices at all. Because it's a shices, it's not detachment in pit. So therefore, the modalities of different treatment also differs.
Also,
Whereas
the fluid is
in
different, sir. It's not
fluid is
coming from
different.
the choroid as in
Yeah.
CSR. It's coming
If
from
you do, if you,
CSR.
yeah. So there have been, people who have done India ink experiments. I don't know, memory is fading, but I remember India ink experiments where people had injected into the vitreous cavity, and like Rohit said, they traced from the optical pit right up to the, and silicone oil also, if you have silicone oil persisted for a long time, Koushik, you must have read, those goes through the pit into the chiasma. And neurosurgeons have drained that oil also. So that has been documented in literature if you go into the lot of peer review articles. But the question is very relevant. The pit is chysis and CSR is detachment.
So optic pit can cause RD theoretically, causing, as you said.
Yes, sir.
You said
Yes.
1/3 cases it can cause, right?
Yes.
Yeah.
Actually,
That
So in
was
round they can answer yes, it can cause.
in medicine,
Reference is
nothing is
causing.
like
no,
it cannot cause, it
no.
cannot happen.
No,
Proful,
Yes, sir.
if the examiner is asking, the reason
Yes.
answer he's expecting is that pit is chysis, pit is not
yeah,
detachment. It can cause,
exactly.
that's a case report, once, but commonly, if you study the OCT also, if you pass the sections, line section through the pit area, you can easily see the communication from the pit to the
To the
sheeting area.
disc.
Whereas in detachment, you will not see that. So answer
Yeah.
if
If
whosoever
somebody
is
asks
asking
the
this question
question in the round to
is
the
as
resident, it is to get this
again,
answer.
yes. Yes, so answer is in PIT you have chysis and in CSR or
Yeah.
RD you have fluid, that is a detachment.
Thank you, sir. Pranita, do you have any questions?
No, sir, I think you've covered all the
Understand.
questions. You have covered all the questions. Thank you so much, sir.
So the questions were quite interesting. Even I had no idea of all the discussion that was just being
Okay.
No,
held.
Praful, that is
Reminding
the
of
whole
our
purpose.
postgraduate round.
Yes,
Yes,
sir.
sorry. That is the whole purpose of this PEP, that anybody can and should ask whatever questions and should clarify doubts, and the speaker or the expert, to the best of ability, will try to solve them. Or you see, all of us are learners. You see, we keep question. I'm sure Praful and Rohit also must have revised something today, so
Yes.
that you see, medicine is interesting because you learn every day. So you learn
Yes,
every
sir.
day
True, sir.
and revise your knowledge, and this makes you a better clinician also. Tomorrow, once I talk to a patient, I tell him, भाई 10 लेयर होती है रेटिना की, आपकी 9 लेयर इधर चली गई हैं, एक यहाँ रह गई है, तो हमें डिटैचमेंट सर्जरी करना है ना, इसलिए सर्जरी करेंगे, बट वी विल अप्रोक्सीमेट द फ्लूइड विल गो अवे, बट विजुअल रिकवरी may take time depending on the chronicity of the RD. If he in the beginning only said that retinal cells will degenerate, they degenerate because of the lack of blood supply. So I think Koushik, in a short span of 30-35 minutes, has done wonderfully well.
Sir, I have a
Thank you, sir.
suggestion.
And I think the takeaway point for all our students today is what Lalit sir said. In medicine, you learn every day. So attend all the classes. You are definitely going to learn something in every class. Yes, Kosik, you were saying something.
Ivasan, you can actually take the fellows or candidates in the same chat room also. They can speak directly to because this will be more
No, no,
interactive if
actually,
they are.
Koushik, there were some issue. Initially, we did some webinars, but the cost was going sky high because we are doing 200 webinars, right? So it would have not been possible for us. Then we took a call, okay, let the speaker be here. Then we'll record these classes, and we have a group of students there. We'll put those classes there, and whoever is not able to watch these classes because of ward duty, casualty, they can also go back and study. So that is we changed this course later on. Initially, it was like all the student used to log in the same portal. Then we subsequently changed it.
And also another thing, just like Dr. Lalit sir said, so focus on the more common things which are there. In exam, you have to tell the common things. Anything can happen in medicine, but the most common thing is what examiner wants to listen from you. So do not tell very rare things because it will fall into trouble.
Anything, Pranita, from your side?
No, sir, I'm really thankful to Lalit sir for making the entire discussion so vibrant and interesting. And thank you, Koushik sir, for in a short span, as sir has rightly highlighted, you've highlighted all the important points. And I think so with that, we can conclude. And you would like to invite for the next class?
Dr. Anita, any comments from your side?
So, sir, Dr. Kaushik, you have covered the topic very nicely, very precisely, important points. And Lalit sir definitely has added a lot to our knowledge. So, we have learned retina as well today. So, thank you so much. Thank you, Lalit sir. Thank you, Kaushik.
So we
It was
so we have
wonderfully covered. Yeah.
so just to before concluding, we had 283 students who were watching your talk, Koushik. But this video, the main highlight of this PEP is live views are 280, 300, but subsequently do people come and watch it a lot because they keep on revising it so that they revise, and see those slides again and again. So that is the best part of DOSPEP.
In 1 week, they usually cross 500, 600 views. So thank you, Rohit sir.
That is what I was coming for. That you see, these are not static things, they are dynamic. Even we also sometimes go back, थोड़ी slides वहाँ से copy कर लेते हैं, because he has worked very hard on this, and they're very useful resource on the. I'm sure Proful must be keeping this resource on the DOS website for long.
Yes,
time.
sir. We have a DOS YouTube channel where we put all these
Yeah.
videos, recorded videos.
Yeah, very nice, very nice. So thanks a lot. Thanks a lot, everybody, for
Thank you, sir.
Thank you
Thank
for
you very
joining,
much.
sir.
A wonderful evening. Thank you very much.
My pleasure. Although I got late, but time पे आ गया था. चल. Okay. Bye, Rohit.
Okay, sir.
Thank you so
Okay.